delivery timings, I think it's important for us to know definitions. Next slide. So in the past, when I trained and when many of you have come along, the term pregnancy was meant for 37 weeks to 42 weeks and then post-term. And the expectation was all neonates between 37 and 42 weeks had universally good outcome. And for the most part, that's true. But as we went through life and delivered babies earlier, we did find that there were certainly neonatal outcomes in that earlier part of the term pregnancy that had morbidities that had significant impact on time of hospitalization and even long-term outcome for those babies. So it was important for us to break down that gestational age range. Next slide. So back in 2012, a workshop was convened, including Society of Maternal Fetal Medicine and the National Institute of Child Health, where they really created a realigned definition group based on neonatal and maternal morbidities that were associated with delivery before 39 weeks. And that realignment set aside early term delivery from 37 to 38 weeks and 6 days. And then full term was after 39 weeks and later, with the late term and post term so defined. Next slide. So we know historically that we had delivered back in the day babies at 37 weeks for very weak indications. And I think that we got a little bit too loosey-goosey with the patients that we delivered early. Then I remember a day when patients were being delivered anytime in that 38th week just for convenience. Either doc was going out of town, a patient wanted a specific doc to deliver them, grandma was going to be in town, so they were just delivered. And we really were not taking into account the baby and the potential for problems. And respiratory morbidities were really being seen more and more. And many hospitals put up blockades saying, okay, you can deliver them early, but you have to have an amniocentesis for lung maturation. And back in the early 2000s, I would do anywhere from 2 to 4 amnios a day for lung maturation studies. And what we found was that even though those studies may be mature, other morbidities reared their ugly heads. There were neurodevelopmental problems, feeding issues with babies, and babies were being in the hospital from 1 to 2 to even 3 weeks being born with mature studies. So the bottom line is elective delivery should only be done at 39 weeks and beyond. But there certainly are indications for deliveries prior to 39 weeks, and that is the basis of this particular committee opinion. And next slide, I really, and this, just look at the first graph, the A graph here. It shows the composite neonatal morbidities at 37 weeks, significantly more morbidities than 38 and more morbidities than 39 weeks. So that's the basis of the data. Next slide. So this bulletin, I've really liked it ever since it came out in 2013 or 2014. This is the latest iteration that was updated in July of this year. We know that there are a lot of maternal fetal placental complications warranting delivery earlier than 39 weeks. And this bulletin helps us put together a group of real common indications, helps guide us into balancing benefits and risk. And it takes into account the suggestions from the workshop results, but plus the updates include the most current data to update the recommendations. Next slide. So I'm not going to go through line by line, but I am going to present this to you, some of the things that I think need to be pointed out, and then we'll do some cases at the end. The first section here, you see general timing, and with each disorder, the general timing just basically says either term, early term, or late preterm. And then the suggested specific timing is just that. It's suggested, but there can be times where we need to weigh benefits and risk and do it a little earlier than is stated in this suggested specific timing. So this is not a proscriptive group of dates to deliver, but sort of a guideline, not a rule, but a guideline. And I think that's where people have made mistakes in interpreting this document. Placenta previa, for instance, late preterm, early term at 36 weeks. Is there a time where you would deliver a placenta previa earlier than 36 weeks? Of course, and we'll do a case about that. Placental implantation disorders, a little bit earlier to avoid problems, 34 to 36 weeks. The classical C-sections and the prior myomectomies used to be treated identically. In the latest bulletin, it says it's moved up that gestational age for myomectomies to 37 weeks because many myomectomies don't really violate the entire thickness of the myometrium. But these are cases that you need to individualize. And I like to look at the op notes on these. If it's truly violating the entire thickness of the myometrium, I think those need to be treated like a classical C-section and done a little bit earlier. Next slide. So oligohydramnios, and that is using the deepest vertical pocket of less than 2 centimeters, late preterm, early term, between 36 and 37 weeks. And that is if there are no other complications noted with the pregnancy. Of interest and of note, something that's been different in the past is if there's isolated polyhydramnios, mild and idiopathic, full-term delivery is suggested. There's no reason to deliver them early, again, unless there are other factors indicating earlier delivery. Earlier this year, or it may have been late last year, there was a really nice practice bulletin on fetal growth restriction. I would encourage you to read it if you haven't. But this is a nice summation of delivery recommendations from that bulletin between the 3rd and 10th percentile EFW to deliver no earlier than 38 weeks if there are no other concurrent findings. Less than the 3rd percentile, so severe fetal growth restriction, a little bit earlier, 37 weeks. If you start to get absent end diastolic flow, then we talk about a much earlier delivery at 33 to 34 weeks, and with reversal of end diastolic flow as early as 30 weeks gestation. And frankly, by the time you start to see reversal of the end diastolic flow, there are almost always fetal heart tracing abnormalities that have led us to intervene before we intervene specifically for the Doppler studies. Also, with growth restriction and either oligo or hypertension, diabetes, other concurrent conditions, late preterm, early term, depending on when the diagnosis is made. Next slide. I'm not going to go a lot into the multiple gestations. Things really haven't changed much here. I'll give you just a second to look that over. It's really the complicated multiple gestations that lead to the earlier delivery. Otherwise, that hasn't changed. The next slide. The hypertensive disorders and then diabetes on the next one are the ones that get the most attention and I think really can help us. Chronic hypertension, not on medications and well controlled, really no need to deliver those patients early. It says as early as 38 weeks, but as long as everything's going okay, the waiting to the 39th week is not a bad thing. Continue testing. The reason for the earlier delivery is decreasing the risk of preeclampsia if it has not occurred yet. If they're on medication, justifies a little bit earlier because those patients are even at a higher risk of developing superimposed preeclampsia. Now, those patients who are having difficult control of their chronic hypertension, you're having to adjust your medications, those are the patients you deliver a little bit earlier, at 30, as early as 36 weeks. If you start to get into preeclampsia or gestational hypertension with severe features, that's when we start talking about delivery at 34 weeks and beyond. But this is where I get confused. I get calls from physicians in practice often, and we forget to think for ourselves because, well, she's got severe hypertension. I'm having a hard time treating it. She's 33 weeks. She's not 34 weeks yet. What do I do? Well, if you're having a hard time controlling their blood pressures, that's an indication to deliver them at that gestational age of 33 weeks. So I think we just have to be cautious, think through the clinical situation, and we don't have to follow these suggested delivery timings to the T. HELLP syndrome, other severe features with neurologic symptoms, stabilize mom, get them delivered just as we always did. Next slide. Diabetes, I think that this has helped us in management of our diabetes patients. And I was very, very glad when this document came out to help in these patients, because patients with vascular complications and poor glucose control have a very high risk of stillbirth. And I remember in the day when we did amnios and did not deliver them until we had mature amnio studies, I would have a stillbirth in a patient at 37 weeks waiting on an amnio result to show maturity. And this takes that out of the picture. If a patient has poor control or vascular complications or a prior stillbirth, deliver that patient early as 36 and even earlier as 34 weeks in certain situations. I think this type of patient requires consultation with MFM to help make those decisions, but it is better to have a baby in the neonatal intensive care unit on the ventilator than to have a stillbirth, which they're at great risk for. Gestational diabetics, typically you deliver at full term, but I have seen and continue to see some gestational diabetics that are poorly controlled that do require earlier delivery, but those are typically very individualized cases, and we talk specifically about those with your MFM. Next slide. And this is, I think, the last group, and the preterm rupture of membranes is one area that has gotten a lot of press and will continue to. I think we're going to see changes in this as we go along, but typically, if a patient is admitted with preterm rupture of membranes, we watch them until 34 weeks and then recommend delivery. There is an increasing push to let those patients go beyond that to 34 and even 30 or 35 and even 36 weeks gestation because of the decreased neonatal morbidity associated with the later gestational ages. Now, there is an exception to that. If you have a patient with preterm rupture and she's positive for GBS, that is not the patient that you want to extend that gestational age beyond 34 weeks because of the risk of neonatal infection. So in GBS carriers, we typically suggest delivery at 34 weeks if they have preterm rupture of membranes. Others that come in with term rupture membranes at 37 weeks, we typically will suggest delivery at the diagnosis of rupture membranes. There are some patients that really want to push it to wait on spontaneous labor. Those patients need to be individually counseled, and we, again, typically suggest delivery at that diagnosis. Next slide. Was there not another slide? Maybe this is it. So I'm going to go on to this case first. A 36-year-old, gravida 4, para 3, known placenta previa. She's had 3 vaginal deliveries before at term. When would you deliver this patient? The guidelines say 30, 36, 37 weeks is typical for a known placenta previa with no bleeding. But what if she presents and has had 2 episodes of bleeding throughout her 3rd trimester and then presents with her 3rd heavy bleeding episode at 35 weeks, which has ceased, but now this is her 3rd significant bleed? What would you do? Would you wait? Would you deliver that patient? And you can use your chat feature to put in comments. What would you do?
So, Barry, first of all, I asked you to do this because I was afraid I couldn't do a great job with it. And I think you did an outstanding job. And the one thing that you can say about that practice bulletin and the guidelines is they are pretty much based on expert opinion, and they're not based on hard data. And what I find to be the most disturbing is that these people are in academic medical centers and they don't practice in Sherrill or Bluffton, or they don't practice in these rural areas where they have limited resources. And so when I have a doctor call me regarding a patient like this, if Barry Campbell called me about this, I'd say, well, Barry, why don't you watch her a few days, give her some steroids and see if we can get her past 36, closer to 37 weeks. But if my friends in Loris, South Carolina, that lives 10 miles from my house calls me, I'm going to say, listen, we got a bird in the hand right here. Her hematocrit's stable. Let's deliver her. And so the thing about those guidelines that bother me the most is it doesn't take into account rural medicine. And then I'll shut up.
No, you're exactly right, and we'll get into that a little bit later. I mean, and this is a particular example of that too. What are your blood bank capabilities? How are you in managing these patients? Is a doctor in the hospital all the time? Do you have a 24/7 physician in the house? But in this particular case, if you have this patient in Lancaster or Sumter or particularly Newberry, I would deliver this patient at 35 weeks. I might try to give her steroids had she not had it, but she's had steroids before because she's been in and out of the hospital. Next slide, Rachel. This is a particular problem for us, and Donna and I have commiserated over this type of patient a lot. 25-year-old G3P2 diabetic, admitted in her 2nd episode of DKA in the pregnancy at 34 weeks. Very limited care. Her A1C at 14 weeks was 8.2, and now on admission it's 10.3. So she's not going in the right direction. And this is one of those where I think the bulletin can help give you guidance, but you have to think for yourself. When do you deliver this patient? Do you try to gain 2 more weeks of this patient to get a baby that's going to have better maturation studies, or do you deliver this patient? Do you give steroids? That's a whole nother debate I'm not going to get into. But this is a patient that I would deliver right now. It's one of those things where bird in the hand's worth 2 in the bush. And I've seen these patients go sour in the hospital while you're watching them develop a 3rd DKA and a stillborn, which is extraordinarily a high risk for this patient at 34 weeks gestation. Next slide. So I've got to move my chat that's here so I can see this. And this is the bottom line. Don't stop thinking. I love this guidance because it is guidance, but I hate it because people read it and they just read the black and white. And you've got to take into consideration where you are. You've got to take into consideration who's managing the patient. There's so many things that require individualized care for determining the correct time for delivery. And it's all clinically based. And what Donna said is exactly right. These recommendations are built on primarily expert opinion. It's the Donnas and the Berries and the Tom Galeys sitting around the table talking about it and literally arguing. I've been on these committees that come up with these recommendations, and we don't all agree on what ends up in print. Next slide. So it's not all inclusive. It's the most commonly encountered indications that we see in clinical practice. Things that aren't included even in the bulletin that it says you need to consider the situation, prior history of a uterine dehiscence, chronic placental abruptions. Be curious to hear what Donna says about more than 5 cesarean sections in their past history. Again, individualized decisions based on the best clinical judgment, and get with your colleagues, get with us, talk through it, and we can come up and help you come up with the best decision. But don't let these bulletins overtake your clinical decision making. If it's a patient with severe features preeclampsia that you would normally deliver, don't let this bulletin sway you by saying, well, the bulletin said to wait until 34 or to 36 weeks. Don't do that. Think for yourself. Individualize the care for the patient that you've got in front of you, and make the best decision that you can make to enhance the clinical outcome for the baby and for mother. And I'll stop there. Got plenty of time for questions, and hopefully somebody will chime in and ask any questions that they would like to, or comments. I'm happy to have comments and critiques of this as well. Thank you.
Barry.
Sorry, Donna, just one second. Do you want me to continue to record, or I'm going to stop the recording and then just open it up so we can all see one another and just talk freely, okay?
Yeah, that's fine. Thank you. Donna, go ahead.
So Barry, the best example